Well, hello everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I will be moderating this event and introducing our speakers. As a reminder, this event is one of many monthly series that kind of alternates case conferences and educational webinars, so be on the lookout for when our next one is. Today, we're going to be having a 30 to 45-minute case conference representing the integrative psychiatry SIG, which will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end with a Q&A session. So if you have questions, put them in the Q&A option. You can feel free to use the chat. You can put comments and stuff, but we're only going to be answering questions from the Q&A option within Zoom. Our trainee presenter today is Dr. Michalla Braford. She's a PGY3 psychiatry resident at Gale Medical Center in Salem, Virginia. And our faculty discussant today is Dr. Claire Brandon, who is the founder and medical director of Whole Body Psychiatry in New York City. And without further ado, I'm going to hand it off to Dr. Braford for her presentation.
Good morning, guys. It's good to have you guys with us. I'm going to start by sharing my screen. All right, so we've got a really interesting case. A 33-year-old Caucasian cisgendered male presented to his primary care physician in February of 2022 for increased anxiety. He endorsed a several-month history of constant, progressively worsening insomnia and anxiety-like symptoms described as generalized worry with restlessness, insomnia, fatigue, inattention, and increased distractibility. The patient denied any prior history of anxiety. He denied any perceived life changes or stressors. There were no exacerbating or alleviating factors. A GAD-7 was performed in the office with a total score of 11, indicative of moderate anxiety. Labs were deferred by the primary care physician as the patient had previous labs, a CBC, CMP, TSH, and lipid panel, for a physical 6 months ago, all which were in normal limits. So the PCP initiated escitalopram, titrated up to 10 milligrams daily, and referred to psychiatry. So when the patient consulted with psychiatry, he reported extensive involvement in sports throughout his life. He said he was the state champion of his high school wrestling team 2 years in a row. And while he was proud of this accomplishment, he noted it was challenging to, quote, cut weight, end quote, often going on starvation diets or exercising excessively before weigh-ins. Since graduation, the patient had started bodybuilding with an upcoming competition in 4 months. So the patient had started to increase his workouts. He was spending in upwards of 4 to 6 hours per day in the gym, often at the expense of sleep. A friend at the gym recommended a holistic clinic focused on supplements for athletes. The patient was evaluated, and he was started on levothyroxine 12.5 mcg to assist with his energy levels. 2 months after taking the levothyroxine 12.5 mcg daily, the patient noticed increased feelings of anxiety. He denied ever experiencing anxiety and was unsure of what he was feeling. He had no family history of anxiety, and given progressively worsening distress, he presented to his primary care for further evaluation. So, reviewing his past history, he had no past psychiatric or medical history. Currently, he was taking supplements including magnesium oxide, 400 milligram at night, CoQ10 supplementation, vitamin D supplementation, 2,000 units, T3, 100 mcg per day, which was prescribed for energy and focus, and escitalopram, 10 milligrams daily. He had no allergies, and he worked as a personal trainer in the wellness industry. No illicit substance use, nicotine, caffeine, or alcohol use. His diet consisted of high protein and high fiber foods. There was no family history of mental illness, substance use, suicide, or medical concerns. On evaluation, his vitals showed a temperature of 37 degrees Celsius, a pulse of 94 beats per minute. His resting pulse was usually 60 beats per minute. His blood pressure was 135/80, respiratory rate 30, oxygen 95% on room air. He was an average height male with muscular build, mildly rapid breathing, no appreciate no appreciable exophthalmos or goiter, mildly elevated heart rate from his baseline. So on our mental status exam, he appeared mildly irritable, little bit restless. His speech was irregular rate, rhythm, tone, volume, and prosody. He described his mood as anxious, and his affect appeared congruent with his mood. His thought process was linear, goal-oriented, and he did not have any suicidal or homicidal ideations. He did not appear to be responding to internal stimuli. He was oriented times 4 with no appreciable deficits in memory or attention. So labs were ordered, including a CBC, CMP, TSH, and T4, and all of those were in normal limits. A UDS was also obtained and was negative. His T3, however, was 250 nanograms per milliliter, so slightly elevated, and his thyroglobulin was less than 1, so low. And imaging, given the lab findings, was deferred at this time. So when we consider a differential diagnosis, some things that pop up, and this is including but not limited to generalized anxiety disorder, hyperthyroidism, eating disorder, pheochromocytoma, and substance use. So this is where we're going to talk about, our discussion, and we have several questions to ask. One is, what are the psychiatric symptoms associated with exogenous thyroid supplement induced hyperthyroidism? What considerations should be taken prior to starting an SSRI in anyone with possible thyroid dysfunction and/or exogenous thyroid hormone use? And why are SSRIs a risk in this case? What are the next steps in treatment? And I am going to turn this over to Dr. Brandon, but I'm going to stop sharing my screen first.
Great. Thank you so much, Dr. Braford, for that wonderful presentation. This is an interesting case that you may or may not have seen in the outpatient world, but I see it a lot, actually, especially with the current, a lot of fitness influencers and industry. People are trying to find ways to use holistic supplementation to help themselves have a little bit of an edge and feel better. So what would be things that you might look out for psychiatric symptoms that might be related to thyrotoxicosis? I think we all have somewhere in the back of our head that we want to make sure we rule out any other medical conditions before we start treating someone for a psychiatric disorder. In this case, this patient's primary care doctor was really trying to help them out. They thought they had a clear medical evaluation, and they started in on trying to treat them for anxiety. But what might be a few clues that would help us to understand that this person was a little bit more at risk for actually having a thyroid disorder or taking exogenous thyroid supplementation? The lowest hanging fruit thing would be the anxiety, right? The anxiety, irritability. These are really common symptoms that are mistaken for generalized anxiety disorder. The edge to that, right, would be a little bit more of the emotional lability, someone having an exaggerated emotional response. They're much easier to cry. Maybe they're getting angry. That could even morph into something that looks a bit more like a manic symptom. Someone in your office is looking very restless, really hyperactive. They're complaining of insomnia, or maybe they're not complaining of insomnia, but you're hearing that they're not sleeping as much as you would expect them to. And they might also have that classic pressured speech. Although that would be, again, probably more on the rare side of things. I would expect someone to just look a little bit more irritable, a little bit more restless. Um, they also may have some hyperactivity symptoms. Maybe you have a patient that has otherwise been well treated for their ADHD symptoms. They're a little bit more impulsive at baseline or have a little bit more hyperactivity, but now you're seeing them in your outpatient office, and that's just not looking like it's under good control anymore, even though nothing else has changed. It would really trigger for me to try to look out for, are they using any other supplements? Is there some other thing to go back and look at as far as their thyroid disorder goes? There's another interesting thing that comes up in these patients, especially with thyrotoxicosis, right? So if they're, not to the critical elevation of their thyroid levels to be in the hospital and be really sick, they might also have something called apathetic thyrotoxicosis. that would be more like somebody who looks like they're depressed. So having more fatigue, more apathy, even potentially pseudo-dementia type of symptoms that we could, again, think might be from depression. But I would think more about this in elderly patients, and maybe they're accidentally taking too much of their thyroid medication, or maybe they are taking a supplement that they just thought was going to be helpful for them. Those patients and other patients also might struggle with a little bit more of their focus, concentration, and to an extreme level, patients might end up having some, paranoia, hallucinations, something that we call thyrotoxic psychosis. And of course, that could be mistaken for schizophrenia. And that's, again, the reason why we'd want to make sure we double checked any of their thyroid levels and other medical workup to make sure that they're not experiencing that rather than a primary psychiatric condition. Insomnia is something that this patient is actually complaining about, which is probably one of, again, the more common things that you would see in these patients if they just have too much thyroid in their system. Maybe they're taking another medication that is elevating the metabolism of their thyroid medication, so they end up having a little bit more and it's contributing to their insomnia. But that's a very common experience with the hyperarousal and increased adrenergic activity in patients who are taking or getting too much thyroid supplementation. And, of course, most of all, I think when somebody starts on thyroid medication, or if they're trying to, again, help themselves out by taking exogenous thyroid hormone, they might also worsen some of their pre-existing psychiatric conditions. So, if you have a thyrotoxicosis, that could obviously worsen a bipolar disorder, a psychotic disorder, anxiety and depression. I've definitely seen that in patients who are experiencing depression already at baseline, and then they result in having even worsening symptoms because they are having the inflammatory condition, the thyrotoxicosis on top of that. So, again, it's just reiterating that a major part of the outpatient CL medical workup is to check and double check a TSH, the free T3 and T4, especially in patients who have new onset or worsening psychiatric symptoms. A lot of times, doctors will check those once a year. And if the timeline, getting a really good history shows that probably something has come up in the last 6 months, in the last 3 months, it's always worth double checking and seeing what that could look like. And that is going into the next question that Dr. Braford mentioned, which is, what would you want to consider before you're starting SSRIs on a patient, especially if someone who maybe has thyroid dysfunction, or maybe they're taking exogenous thyroid hormone. So there's a couple of things to think about there. TSH suppression or elevation can result in these cases. A couple of the major culprits in the drug world for this would be sertraline and fluoxetine. They can cause TSH suppression. It's not fully elucidated, but likely that has to do with the HPA axis having an abnormal increase of serotonin activity in these cases. Again, just a plug for really making sure that you're double checking their TSH. We always think in hindsight, gosh, I wish I had that TSH level to compare. And if you don't get it, you don't have it. It can also result in elevation of TSH levels. Sertraline and paroxetine can reduce T3 and T4, which would increase up the TSH levels. Again, probably due to the HPA axis. It could also have to do with competition in the hepatic metabolism of these drugs. And then there is also some dysregulation of enzymes that have to do with uptake of iodine in these cases, which again could dysregulate the thyroid. So, you want to think about anything that you're seeing in these patients that could have an overlap symptom. And in this case, the patient the primary care doctor had done a PHQ-9 and a GAD-7, which was great. Again, big props to the primary care doctor for doing some of this workup. But what I would encourage you to do, even outside the hospital, is the hospital anxiety and depression scale, so that you can try to be a little bit more objective about mood symptoms versus the physical symptoms that often come up in these cases. Why would SSRIs be an issue in this case? I mean, the overall thing is that if you have a thyroid dysregulation, you're kind of just throwing fuel onto the fire, and it muddies the waters a little bit. You don't know what the TSH looks like. You don't know, if it could be the thyroid. Does this person actually have a baseline level of anxiety that's coming up? Is it an induction from the SSRIs that they're actually having a negative response to? And the really big downside in my head to that is that patients may say, like, forget it, I have a bad side effect from SSRIs, I don't want to take those anymore. And we sort of lose, in that case, of a patient getting treatment potentially in the future when they're not taking exogenous thyroid or they're not having issues with thyroid. When the patient is, feeling better from the thyroid supplementation, or if they are somebody that needs thyroid supplementation because of a disorder, it's worthwhile to think about the SSRI as still being safe and being able to treat some of those symptoms that are linked with thyroid disorders like depression and anxiety, of course. So, what are the next steps in treatment that would be appropriate for us as psychiatrists, as a CL psychiatrist, to do here? And I would say that, the first, most obvious would be to try to get this person to stop using the exogenous thyroid hormone, if that, in this particular case, that's what they're doing for supplementation. Often I get endocrinology involved in that. Of course, I'd be speaking to their primary care doctor to do the liaison work, but I would also want to make sure that I had somebody who was able to monitor that and do some serial labs to double check. Remember, thyroid can take months to actually re-regulate. So you want somebody who knows sort of the time frames for that and can be monitoring for you. I would probably, depending on the dose, discontinue the escitalopram here, because it's not clear to me that the patient has primary anxiety, and we might be muddying the waters again. If they're really struggling with adrenergic symptoms, right, like tachycardia, increased anxiety, the insomnia too, I might be reaching for a beta blocker like propranolol. It's not, a harmful medication. It's been around for a long time. People don't feel like it's a psychiatric medication in a lot of cases, so you can get their buy-in to taking that. And that can just help them overall feel a little bit more like they're going in the right direction, and encourage them to keep up with treatment and to make sure that they're not taking these exogenous medications. And then I'd probably consider, even though I know it's a bad word, I would consider treating them with a benzodiazepine short term at low doses for the anxiety and insomnia that they're experiencing. So for me, if I'm still seeing this patient, if they're wanting to follow up, I'd probably follow up with them as soon as they're willing to follow up. But at the very least, in 3 months, when their thyroid theoretically could be re-regulated, and checking in with their endocrinologist or their primary care doctor just to see, how is their anxiety doing? Let's redo some scales. Let's make sure their thyroid looks okay, and see, potentially they're a candidate for future treatment of their anxiety if they're still suffering with that. So with that, I will send it back to Dr. Braford to tell us about how the case concluded.
Yeah, thank you, Dr. Brandon. So I'm going to pull my slides back up. All right, so our update. So kind of like what Dr. Brandon was saying, we discontinued the thyroid supplementation and started them on propranolol, uh, oop, propranolol 10 milligrams twice a day as needed for their symptoms, and lorazepam 0.5 at night for insomnia. A referral was placed to endocrinology, and the goal was monitoring thyroid levels in order to avoid any rebound or suppression of thyroid. And they were advised to follow up with psychiatry in 2 months. So at the time of follow-up, the patient noted considerable improvements in their anxiety, insomnia, and concentration, though continued to experience some fatigue. The goals of treatment included focusing on building a sustainable work-life balance with his fitness career and minimizing constant exhaustion from working out. So, what is our role in providing education as CL psychiatrists? Well, it's kind of twofold. One, with primary care and endocrine. So, coordinating care and discussion of discontinuing escitalopram, as well as adding a beta blocker and lorazepam. And then we request for follow-up labs for medical clearance if future treatment is needed. With the patient, we discuss the importance of engaging primary care physician with all medical treatments prior to adding supplementation and medication regimen. And we emphasize the importance of endocrinology follow-up to assist in management of thyroid hormone levels, follow-up in 6 to 8 weeks or sooner with psychiatry to evaluate anxiety levels and determine whether further psychopharmacological management is needed. I'd like to acknowledge Dr. Brandon, Dr. Fipps, and Trish Harley for all of their support and assistance. And with that, I'm going to turn it back over to Dr. Fipps.
Excellent. Thank you very much. A great case presentation and very good discussion as well. We're going to now move into the question and answer part of the webinar. And as I said at the beginning, make sure you put your questions in the Q&A option. Those are the ones that we'll be answering, though feel free to chat in the chat if you wish. We've already got a few questions in the Q&A option here, and we're going to go through a few of these. So one of these was, you mentioned, Dr. Brandon, that it's good to have a good comprehensive thyroid panel when having these concerns. One of these questions says, usually the T3 and thyroglobulins are not commonly checked if the FT4 and TSH is unremarkable. What are your thoughts about when you would indicate getting these extra parameters in these clinical cases?
Yeah, thanks. That's a great question. Actually, you're right. And most primary care doctors and endocrinologists are not super excited to think about testing extra labs. And of course, and making sure we're not doing too many things in medicine is important. But if I had a patient that had a new onset anxiety or depression, and as I'm pointing out in some of these medications that we could start, we could result in some suppression or elevation of the T3 and T4 levels. I would really just want a good therapeutic baseline to understand if there was any abnormalities that resulted from these medications. I'm also a little bit more conservative on making sure I have as much information as I can. I want patients to have a really good experience with SSRIs. So if we're starting in on that, making sure that I have all the information possible, I think is more helpful, and it gives the patients a little bit more data as well. I would also think about this if somebody had a genetic predisposition to thyroid disorders. So getting the full panel baseline in somebody that might have a family member with Hashimoto's or something like that. I think that would be another helpful reason as to why to get that.
Very good. Very good. Thank you. And when we talk about time frame of how long you'd be following someone, that's a common question that gets asked. You mentioned you'd want to follow up in 3 months to kind of see if there was a change in symptom presentation, but how long do you think these individuals should be followed after symptom resolution? And or if there wasn't symptom resolution, kind of what would be some of your next steps, do you think?
Yeah, definitely. So if there was symptom resolution, usually I would tell them they get to graduate from me. They don't have to keep seeing me anymore. If they, especially if they're not interested in there's nothing else they feel like they need to work on. But if a patient is not having resolution of these symptoms once they've been cleared by endocrinology, for instance, then we would try to dig in a little bit more and understand, is there something else going on, right? In this case, maybe this patient was showing a few signs of having a little bit more body insecurity. They were trying to do a lot of athletic things. They wanted to really show up as their best. So maybe there's some performance anxiety involved in that. Maybe there's some other things to tease out. So in that case, I would start thinking about other ways of either psychotherapy or psychopharmacology treatments for them to see if there is any other diagnostics to find out if they have generalized anxiety, for instance. Still maybe using that HADS scale so that we can parse apart any other medical symptoms, but trying to monitor that over time is helpful to see if that changes or if they are staying consistently at an elevated anxiety level.
Very good. And when we have experience in these types of presentations, sometimes this comes from, as we see here, to where he was taking it in that perspective and where sometimes it's getting prescribed. But do you speak of the role maybe of CL psychiatrists reaching out to some holistic clinics and providers that inadvertently cause harm by prescribing these treatments?
Yeah, I try to do that a lot actually. And what I'd say is that sometimes they're open to that and sometimes they're not open to that. I have seen a number of, I'm in New York City, so there's a lot in the wellness world of like how to get the best for, like your optimized life. And I think, of course, we all know that that can definitely have a downside to it. So I definitely will call them. I will, speak to them in the same way that I'm doing liaison work in the hospital and the outpatient world to make sure that I'm speaking to them as a colleague, trying to educate and saying like, hey, I'm really concerned for this patient. If you always put the patient at the center of what's going on, you can get people's buy-in a lot easier so that it's not me against you. It's how are we helping these patients? And, maybe in the back of their head, hopefully they hear that and say, yeah, okay, like we should advise or double check and make sure they don't have some other pre-existing anxiety, or being more thorough about checking their labs before they're recommending those things, ideally.
Ideal, yes. Nice. And a lot of times, when we talk about these, there may be sometimes differences in how people present. I know this was a fairly young, healthy individual. Is there a difference in kind of how people present based on their age or their comorbidities, especially, because sometimes this takes a close eye to catch that this may be a contributing factor?
Yeah, it's certainly different in the age ranges, and it can be different in genders as well, right? If you're seeing someone who's in your reproductive psychiatry clinic, how do the thyroid levels change, and how are they reflecting anxiety or things in that case? And I would say that one of the biggest ones to point out and to think about is that younger people, healthy generally people, can tolerate this to some degree, right? If they're using supplements, it does take a critical mass for them to get to a place where they show up as like a more ill compared to a more fragile patient. So somebody that's already a bit smoldering in the autoimmune world, if they have other autoimmune conditions or they're more critically ill, and then especially elderly patients in this case, that as I was mentioning, they could have symptoms of pseudo dementia. They could look like they have more of the downregulated symptoms of their thyroid, some more depression type of symptoms, and they would probably show up a lot quicker than somebody else who had a little bit more space to tolerate throwing in extra supplementation to their system.
Excellent. Thank you for that. And you did quite a bit of discussion about how some of our medications may interfere and intertwine with this type of supplementation, mentioning aspects of hepatic metabolism as well as HPA axis. Are there ones that we would be more concerned about, or maybe, or the better term, less concerned about if this individual actually had an underlying anxiety type disorder and we wanted to impart treatment? Can you speak a little bit more about some of our medications and how we could intertwine that with those parameters?
Sure. Yeah, it seemed like, and I was going back and reviewing this as well, that some of the biggest culprits, especially in that HPA axis, serotonin metabolism, are more like the fluoxetine, the paroxetine. So, probably people are using paroxetine a little bit less because of the weight gain side effects to it. But the fluoxetine is one that we always reach for, right? That's just like a bread and butter medication for us. And I think that we don't have to be so concerned about it and say, oh my gosh, I'm going to create some kind of thyroid abnormality for all these patients. But it's something that it should be in the back of your head. If they're really not tolerating the medication, if they're really having an elevated response to it, it could be that they're a little bit more sensitive for this reason. They might have a genetic predisposition to increase serotonin metabolism in that area of their brain. And the competition with the hepatic enzymes, we always are thinking about that, and that also would take, we're all CL psychiatrists, and we're all thinking about, how do different drugs interact? How are we using some of that interaction to our benefit? How is it going to maybe be a deterrent for us? So some of these drugs like fluoxetine and paroxetine, they tend to be some of the drugs that have a lot more interactions to them. So that's why they're showing up here as they might be more culprits in the hepatic metabolism. And I think that the most, maybe the more interesting one, again, paroxetine, not used as frequently, but it does have some inhibition of iodine uptake, and it impacts some of the enzymes that take up iodine in our system. So if you started seeing somebody with abnormal T3, T4 in a patient taking paroxetine, you might think to yourself, okay, like maybe they have a little bit more of a genetic predisposition to that enzyme abnormality as well, and they would benefit more from a different drug in that case.
Gotcha. Very helpful. Very, very helpful for that. And kind of in the last minute, I would say if he continued to have anxiety and it remained elevated despite stopping the offending agent, what would be your thoughts about some of the next steps for him then?
Yeah, if he didn't hate escitalopram at this point, I would consider restarting him on something like that, to see if he could tolerate it, to try to treat some of the anxiety. But this person being really invested in the wellness industry might also benefit a lot from cognitive behavioral therapy for their anxiety, from dealing with some things with their sleep hygiene, really doing CBTI for their sleep, trying to get their buy-in to optimize other factors in their life, and not doing a lot of med education of not taking extra supplements, trying to just do healthy behaviors, and then taking it one step at a time if they wanted to consider psychopharmacology. But it's not clear to me that this patient would necessarily need that. They might take really well to CBT. And if not, then we could always go down the path of trying out an SSRI again.
Excellent. Well, thank you very much. I appreciate the case presentation, the discussion, the excellent question and answer, and the audience involvement as well. You were all very good with giving us plenty of questions to ask. And as a reminder, the video recording for this is going to be on the ACLP website. It'll be at Twitter at CL Psychiatry and on the CL Pin Facebook page as well. And be on the lookout for when our next webinars are coming up. But otherwise, I appreciate everyone coming, and I say you have a good day.